Hello, my name is Jacob Batiki, and I'm the Director of Education and Advocacy of the University of Miami Public Health Policy Lab. The UM Public Health Policy Lab and the AHF Global Public Health Institute are honored to welcome you to our Emerging Topics in Global Public Health webinar series, a forum dedicated to knowledge exchange, rigorous discussion, and actionable solutions. It is with gratitude that I extend a warm welcome to our distinguished panelists, Dr. Yewande Alimi of the Africa CDC, Ms. Ella Balassa, Patient Advocate and Head of Balassa Consulting, Dr. Paula Lichtenberger of the University of Miami, and Ms. Carol Ruffle of GARD-P. It is now my pleasure to introduce our moderator for this session, Dr. Gio Baracco. Dr. Baracco is Professor of Clinical Medicine at the University of Miami Miller School of Medicine and a leading figure in infectious diseases and hospital epidemiology. After earning a MD from the Universidad Peruana Cayetano Heredia in Lima, Peru, Dr. Baracco completed residency and fellowship training in internal medicine and infectious diseases at the University of Miami Jackson Memorial Medical Center. Over the past 2 decades, Dr. Baracco has led various leadership roles at the Miami Veterans Affairs Healthcare System, where he currently serves as Associate Chief of Staff for Hospital Epidemiology and Occupational Health. Nationally, Dr. Baracco serves as medical lead for the VHA Multi-Drug Resistant Organism Prevention Program and as senior advisor for emerging infections to the VA Undersecretary for Health. Dr. Baracco, we are deeply grateful for your leadership and for guiding today's conversation. Once again, thank you all for being here. I look forward to an insightful and thought-provoking discussion. Dr. Baracco, the floor is yours.
Thank you, Mr. Ratiki, and welcome everyone to today's webinar. It is my great pleasure to moderate this distinguished panel of speakers. And just as a form of setting the stage here, we talk about antimicrobial resistance as a global health threat, which it is. But I think that antimicrobial resistance is also symptomatic of a much larger set of social and governmental issues, and we're going to be talking about that. So there are issues like regulation of antimicrobial usage, poor access to formal care by individuals. There are cultural issues, such as the perception of the quality of care depending on what or how strong the antibiotic is that you get, or the free access to antibiotics in certain countries, animal use of antimicrobials, liability issues. So all of these kind of mount up to a worsening crisis in the world, and the consequences of this are significant, right? So the consequences could be that individuals that have this perception that there is high levels of antimicrobial resistance tend to prescribe even broader antibiotics or more toxic antibiotics or more expensive antibiotics. All of these get compounded into developing even more resistance. There might be delay in getting effective therapy for some patients, or lack of effective therapy altogether for many of them, and we're seeing that more and more. That, of course, increases cost of care, increases outcomes of individuals. But more important than all of that is that all of these numbers and statistics that we're going to be talking about, they reflect people. And these people are the ones who suffer or can't get proper care for their diseases. So in this conversation, I'm really hoping that we will explore the breadth and scope of antimicrobial resistance using this more holistic lens, and discuss some path forward. And with this, I'm going to go ahead and introduce our first speaker. It is my pleasure to introduce to you Dr. Paula Lichtenberger, who is my friend and colleague. And Dr. Lichtenberger is a professor of medicine at the University of Miami School of Medicine and chief of the infectious disease section at the Miami Veterans Affairs Healthcare Center. She chairs the antimicrobial stewardship program at our hospital and serves as Associate Program Director for the Fellowship Program at the Jackson Memorial Hospital, University of Miami, Infectious Disease Fellowship. She's an international consultant for the Pan American Health Organization and has a professional interest that's focused on antimicrobial stewardship, education, and global health and disaster preparedness. Dr. Lichtenberger has authored more than 50 publications, and her collaborative projects have involved numerous ministries of health and hospitals throughout Latin America and the Caribbean. So, Dr. Lichtenberger, take it away, please.
Thank you, Dr. Baracco. I'm going to share my screen so I can share with you a couple of slides. So thank you all, and very glad to see that there's people interested in the same topic that I'm actually passionate about. So I could say that is not only part of my career, my passion, but also my hobby. So within the next couple of minutes, I'm just going to share with you a little bit of the scope of what's going on in antimicrobial resistance in Latin America and the Caribbean and what's happening, and from at least the part that I can share with you that is my experience as an infection consultant for the Pan American Health Organization. So a little bit about Latin America and the Caribbean. We know that from a big study in Lancet showed that in 2019, there were 5 million deaths attributable to multi-drug resistant worldwide. From those, Latin America and the Caribbean contributed for about 600,000 deaths. And still, in many of our countries, is still the third cause of death. So those are news that are, highly respectable and definitely show that there's a lot to work to do in our area. The biggest killers in our regions are still, number one is Staphylococcus aureus methicillin resistant, although the prevalence is not high, it is still the number one killer. Number two is Acinetobacter baumannii, carbapenemase positive. Number three is Pseudomonas aeruginosa, carbapenemase producer. And the fourth is Klebsiella pneumoniae, carbapenemase producer. Talking a little bit the barriers, and again, I'm sure that because with the colleagues that we're going to talk, probably we know that we all share the same barriers that comes from all our low and middle income economies. So from many studies that had been done, what has been showed is that first of all, there's a little lack of leadership support, and more than support, I will call it kind of diversity in terms of the national systems and the policy systems in the different countries in the region. There's lack of action plans and policies. We will talk later about the global action plan, but definitely there's a lack of formal laws or formal plan from many countries to guide or to lead the way in terms of how countries are going to combat the resistance. And that's probably the most important fact for me in terms of for a country to organize how we're going to combat antimicrobial resistance. Definitely, there are problems in terms of the antimicrobials are dispensed without prescriptions, and there's a lot of self-medicated with antimicrobials in our region. From human resources, we have a lack of expertise in terms of we have very few infectious disease practitioners in the area. If we have few infectious disease, we have even less clinical pharmacists and even less clinical pharmacists with expertise in clinical microbiology and pharmacology of antimicrobials. There's a lot of burnout, hierarchical problems. In terms of behavior, we found out that about 50% of the patients that get admitted to a hospital in Latin America or the Caribbean receive antibiotics. And to put in perspective, high-income countries have about 30% of that incidence. Empiric use of antibiotics is the number one reason why providers prescribe antibiotics. There's a lack of evidence-based guidelines with local data for prescribers to guide their antimicrobial use. Lack of technology, paper charts on prescriptions are still around in the many countries. Hospitals without microbiology laboratories, and those who have microbiology laboratories, they don't have the way how to structurize and plot it into a more efficient system. There's lack of surveillance. There's larva and glass that we're going to talk later, but we know that there is lack for that. Poor access to high-cost antimicrobials and an aging population that we know increase the risk of mortality for multi-drug resistant organisms. What the Pan American Health Organization is doing, they lead the global action plan in the American and the Caribbean. They support the nations to develop their the national action plan. And right now, I'm just mentioning the ones that I'm helping or trying to reinforce with the Pan American Health Organizations as reinforce laws and policies in terms of dispense antimicrobials only with antimicrobial prescriptions, policies to implement antimicrobial stewardship programs in hospitals that comes from a national law, surveillance systems to try to get nations to get into the glass for blood surveillance system for antimicrobial consumption and antimicrobial resistance surveillance, support implementation and strengthening hospital antimicrobial stewardship. That's kind of like my core, in which we do diagnosis and help these hospitals. We help countries to access to high-cost antimicrobials by different projects. We help them with communication campaigns to communicate for the population about the problems and the consequences in awareness on antimicrobial resistance, and pharmacovigilance and telling to help pharmacists to do audits and checklists. All these projects in terms of what we call a One Health approach. That means that is not only for human health, but also animal, food, and water systems. So this is in a nutshell the problem and what we are doing. This is just a picture of what it takes a village to do effort. That this is just a minimum, the little grain of salt of our group that is working through the Americas trying to combat some of the problems of antimicrobial resistance.
Thank you so much. That was really interesting. Now it is my pleasure to introduce to you Dr. Yewande Alimi. Dr. Alimi is the One Health Unit Leader at Africa CDC and co-lead for the African Union Task Force on Antimicrobial Resistance. She co-chairs the IPC section for COVID-19 response across the continent, provides technical infection prevention control support sorry about that. And provides technical infection prevention control support to the Africa Task Force for Coronavirus. As the One Health Unit Lead at Africa CDC, Dr. Alimi has been at the forefront of developing and implementing comprehensive strategies that bridge the gap between human, animal, and environmental health. Under her leadership, Africa CDC has established crucial programs addressing antimicrobial resistance, zoonotic diseases, food safety, and climate change, effectively addressing critical One Health issues across the African continent. With her diverse background encompassing veterinary medicine, public health policy, and research, Dr. Alimi oversees the implementation of various strategies, including the Africa Union Framework for Antimicrobial Resistant Control and Africa CDC's Framework for One Health Practice. Dr. Alimi, the floor is yours.
Thank you very much. Please confirm you can see my screen.
Yes, we can.
Fantastic. Good afternoon, ladies and gentlemen. It's my pleasure to really take off from the last speaker, really highlighting what the African continent contributes to the AMR discussion. I think it's quite significant that to highlight the Africa's sort of share to the global burden of AMR. Globally, Africa has the highest share of AMR, which is estimated to increase to 40% by 2050. Just to put that into numbers, it's the numbers we show right now show about 1 million Africans die as a result of associated with AMR, and is estimated that if nothing is done when it comes to implementing the national action plans and the global action plans on AMR, by 2050, about 4 million Africans are at the risk of death as a result of AMR. But I think it's quite important, in addition to what has been highlighted as per the critical needs for health architecture on AMR, is that across the African continent, there's a significant issue of access. We estimate that about 20% of patients across Africa lack the access to affordable antibiotics at the right time, at the right cost, at the right dose. And of course, this has significantly contributed sort of to the GDP across the African continent. But I think it's quite important to show what the pathogens look like across the African continent, just to complement from the PAO region. Recently, Africa CDC, as well as other partners, conducted a multi-country, multi-year report, data analysis on AMR. And across the African continent, across the 14 countries in this study, only 5 out of the 15 WHO priority pathogens were being prioritized for testing across these countries. But I think most significantly is the disparity in terms of diagnostic capacity. Across these 14 countries, it already shows that only 1.3% can conduct bacteriology across these countries. And as you can see, these are the pathogens highlighted in the MAP study as part of the pathogens of concern for the African continent, widely distributed across the 14 countries. Like I rightly mentioned, I think a few things are very essential to how we can implement and address antimicrobial resistance across the African continent. One is to take on AMR not just from the perspective of introducing new antibiotics, but really addressing the critical health issues such as access to diagnostics, access to antibiotics, but significantly also thinking about it from the UHC perspective. So in this regard, a few things are critical to how we address antimicrobial resistance from an African-centric point of view. We align with a lot of the global AMR priorities, which includes accountable governance, a One Health approach, whereby it does not just limit to human, animal, and environmental sectors, but also takes on the finance, trade, as well as other relevant sectors within the government. Also is the agreement with the UN Political Declaration of 2024 that across the world, we need to have strong target settings and surveillance mechanisms for us to be able to see how well we are doing in the control of AMR. Lastly, of course, is around the conversation of financing and resource mobilization, whereby LMICs can have a sustainable approach to implementing their national action plans. But at the center of Africa's AMR response, we must be able to focus on a few priority issues, which is one, increasing preventive measures, such as WASH IPC, good stewardship, animal husbandry practices, environmental management, and alternatives to antimicrobials, but also significantly understanding that there is a wide inequity across access, means that globally we need to approach AMR in such a way that we can ensure that there are mechanisms for equitable, affordable access to quality medicines, vaccines, diagnostics for humans and animals, recognizing that prevention and access might be a bestseller for LMICs. Lastly, it's just to put it together in what we are doing as Africa CDC and the Africa Union. One is a few critical elements that are already highlighted in the landmark report by the Africa Union is on how do we address the AMR drivers in the African context, recognizing that we need to ensure that there's an increased support for prevention, like I already mentioned, and access, but also understand that we need to support programs that strengthen health systems and regulatory frameworks. I think for now, as we have seen the world change globally, it's important that we need to address AMR not as a silo topic, but also as an essential element of the universal health coverage. Also, it's around creating guidelines that can ensure that we have a bit of harmonized core indicators across countries over time, such that it's no longer a LMIC versus high-income country conversation, but a global conversation where we can measure the progress on AMR. Also, apart from that, is also the peer-to-peer learning, as well as ensuring that we can mobilize, coordinate resources at a national level, regional level, as well as a global level for us to be able to implement the national action plans. I think lastly is on ensuring that funding is not only donor-driven for LMICs, but it's a predictable, equitable, and sustainable access across all countries. Thank you so much, and back to you.
Oh, thank you so much for that presentation. That was really important. My next honor is to introduce you our next speaker, which is Ms. Carol Ruffle. Ms. Ruffle serves as the Africa Director of the Global Antibiotic Research and Development Partnership, or GARP, where she leads initiatives to strengthen access to sustainable and equitable treatments for drug-resistant infections across the continent. Ms. Ruffle is an experienced public health specialist with deep expertise in HIV/AIDS, tuberculosis fields, and extensive insight into the Southern African health sector. She has over 2 decades of experience spanning the corporate pharmaceutical industry, including senior roles at Johnson & Johnson, GSK, and Addock Ingram, as well as community pharmacy practice. Her leadership blends technical knowledge, programmatic strategy, and partnership building across public, private, and multilateral sectors. She holds a Bachelor of Pharmacy from Rhodes University, a Master's of Public Health from the University of Liverpool, and a Certificate in Business Project Management from the University of Witwatersrand. Without further ado, Ms. Ruffle, the floor is yours. Thank you.
Thank you, and thank you very much for the invitation. I'm going to just share one single slide, and I think much of what I am going to say, I think really builds upon what the first two speakers were highlighting. And again, obviously, I'm coming from the African perspective. I just want to try and get this out of the way. So I'm going to try to just use the example of neonatal survival or the impact of AMR on neonates, and really start with just some of these high-level points and then drill down a little bit. By 2050, the projections are that 40% of our global births will be taking place in Africa. So as we know, this is a young population, and unlike, I think, the PAHO or the Latin American slide, where it's an aging population, we have both. We have this young burgeoning population and a lot of births to cope with. Over 1 million neonatal deaths at the moment in Africa. And this projection will set to continue that because of the majority of the births, we're going to unfortunately also witness the majority of deaths. But we are not seeing any kind of shift in the mortality in Africa, and I'll dig into that in not with slides, but just with a narrative over the next few minutes. I'm going to stop sharing and just then be able to talk to the group. So this focus on neonatal mortality, I'm sure many of you are aware that we have an SDG 3.2, which is aiming to prevent or end preventable deaths by 2030 of newborns and children. So AMR is a huge factor and now is recognized as not only an obstacle for Africa to be able to achieve this SDG, but in some cases actually threatens to reverse many of the gains that may have been made over the last decades of improving neonatal mortality. So I'll talk a little bit about both the indirect and the direct consequences of AMR and try and, I think, draw similar themes to some of the previous speakers or repeat some of the similar issues. So, of course, it's a no-brainer that as we start to get AMR in the common neonatal infections, they become harder to treat. So the kind of percentages, if you have a normal susceptible infection, you are still getting some neonatal mortality, but probably in the area of about 20%. As these infections start to become more and more resistant, you start to see mortality creep up to the 40s, 50s, 60s, 70% in terms of mortality. Many of the leading causes of neonatal deaths are bacterial infections causing sepsis, pneumonia, meningitis. And I think what we're seeing is that while we have some gains from interventions about safe childbirth, what does happen is that you then do get more of these neonates that are requiring some kind of hospitalization, but our hospitals are now becoming overcrowded. The NICUs, the intensive care units, are becoming overcrowded. The IPC is not managing to keep up. And so you, of course, have this creeping resistance, but also outbreaks where sometimes an entire ward can be severely impacted and you have mortality. And of course, from a social perspective, that really starts to erode the trust in the health system, as you can imagine, in a community when you have an outbreak and really, critical mortality happening in a ward. I'm not going to mention the pathogens. I think really from the Latin American experience, we know that these gram-negatives are increasing in resistance and are commonly, I don't want to say available, sorry, that's the wrong word, but commonly present in our intensive care units across Africa, Asia, and obviously you heard from Latin America. But then the next step, which Dr. Lemi has alluded to, is that certainly in the low resource settings, we often then don't have the access to the antibiotics that would then work. And if they are available, and by available, there's a whole host of activity that goes on, registration, commercial availability. So even if they are available, they can be too costly for the public health systems to access them. And then importantly, they may not have the access, these hospitals may not have the access to the microbiology that Dr. Leamy was alluding to. Again, even if it is available, are they using it and can they afford it? So you do get this sort of vicious circle of then babies dying from infections, even though they should otherwise be curable, should the right antibiotic be available. The next kind of societal step, I guess, or somewhat into the ecosystem, the more that we have these drug-resistant infections, it means longer hospital stays, more expensive drugs, higher level of care needed. But ultimately, this is going to put a drain on healthcare resources, diverting the limited resources away from maternal and child health programs. So again, just a vicious circle around SDG 3. Last point I will make. Wendy's already talked about global health inequities, so I'll make a last point around how AMR sort of undermines data and accountability. In many countries, neonatal deaths would not be coded or associated or allocated to an AMR issue. They are simply recorded as a sepsis or an infection. So this is really starting to hide all the real burden of AMR and delays the coordinated action and funding that we need to go into combating neonatal health. Back to you.
Thank you so much. Last but most definitely not least, it is my pleasure to introduce to you Mrs. Ella Balazza. And Ms. Balazza is a patient advocate, biologist, and writer. She's dedicated to amplifying the patient voice in research and healthcare innovations. Living with cystic fibrosis, she bridges her scientific background in microbiology with lived experience to promote patient-centered approaches to drug development. In 2019, Ms. Balazza coordinated her own experimental phage therapy treatment with researchers at Yale University, becoming one of the first U.S. patients to receive it. Her successful outcome, covered by the Associated Press, helped raise global awareness of alternatives for drug-resistant infections. She now serves on the PCORI Rare Disease Advisory Panel and the Clinical Trials Transformation Initiative Steering Committee, and contributes as a patient reviewer for BMJ and pulmonary therapy journals. Ms. Balazza regularly speaks at conferences, congressional briefings, and with pharmaceutical leaders on advancing equitable, patient-engaged research. Ms. Balazza, welcome.
Thank you so much. Thank you for having me, and really appreciate all the previous speakers and of that introduction. So I am Ella Balazza. I have cystic fibrosis, which for those that aren't quite as aware, it is a rare genetic lung disease that primarily causes a buildup of thick mucus in the lungs. And this mucus attracts bacteria from the air I breathe in, and since childhood have dealt with very severe lung infections due to Pseudomonas and a number of other Staph aureus, a number of other microbes as well. So over the course of my life, I have had to combat these infections, have had to take many, many courses of antibiotics. And over time, as these antibiotics, as the bacteria have gained resistance, and the antibiotics have lost their effectiveness in treating these infections, I have experienced the increasing symptoms of antibiotic resistance and these infections that are no longer responsive to antibiotics. And so someone in my early 20s, I was in college, I studied biology, and then subsequent to graduating, worked in a microbiology lab. And some of the intersection between the work that I was doing in the lab and my own body and what was happening in my own lungs really interested me. And so we were looking at, in the lab, we were looking at the antibiotic resistance present in river water in environmental samples, and those same bacteria that Pseudomonas, and for example, that thrive in environments also thrive in the lungs of people with CF. And so, so from this work, educating just bringing more awareness to the problem of antibiotic resistance from a global perspective and from an environmental perspective, I started to realize the ways by which I could bridge these gaps and be more of a voice for patients and understanding not just research and health concepts, but the problems of antibiotic resistance as a whole. And around that same time, I dealt with a very significant and very serious infection for which I sought out phage therapy, which is the use of a very specific specialized virus to attack a bacterial host. And so this experimental treatment and its success led to me really wanting to raise awareness and be a voice for not only the problem of antibiotic resistance for those that chronically use antibiotics, but really, as for a global population. And so I initially was asked to share my voice and share my experiences as part of, the Infectious Disease Society of America. I was interviewed for a number of other documentaries and speaking to presidential advisory councils, and then was selected to be on the World Health Organization's AMR Survivors Task Force. And last year spoke at the General Assembly high-level meeting on AMR, urging world leaders to act proactively to fight against AMR and create necessary policies, bolster investment into new treatments and technologies, and really convene resources and assemble stakeholders. So now in a lot of the work that I do, while it's really to bring a voice and bring a face to the problem of antibiotic resistance, to really humanize the issue and help people understand not just the statistics, but really come to have empathy for and have the emotional, move people with emotion to make people aware of this problem and how it actually affects people every single day. And so that combined with the ways by which we can, motivate and leverage policy and innovation and get investment into creating new novel therapeutics to treat these types of infections is by way by which we are going to, move the needle and not have those statistics come to fruition, with as potentially a rise of 10 million people, affected by antibiotic resistant infections by 2050. So, that requires focus on novel rapid bacteria testing and also stewardship programs and such. And so really I just urge our global leaders and our many stakeholders to come together and address this problem for patients like me and many others.
Thank you so much. And your discussion, your description of your own journey brought up many different thoughts and very different memories, just to share a personal one as well. And I cannot imagine being the parent of one of those newborns, for example, who die from an antimicrobial resistant organism, maybe because there isn't the resources, or maybe there isn't access to the proper high-level expensive antibiotics. But I mean, in a more milder level, last year, actually it was earlier this year, my father was developed a urinary tract infection, which was not complicated, but it was with a very resistant organism. So he had to be hospitalized for intravenous antibiotics, very expensive and whatnot. And it happened to be the day of the wedding of one of his grandchildren, which he had to miss. And so there is a personal affection, and I want to, there's a whole spectrum from the very mild, well, you missed a wedding, which is important to you, all the way to the incredible, difficult journey that you have endured, and all the way to people dying unnecessarily. And I think it is important to, again, humanize these statistics and these numbers. So let me ask the panel, and this is going to be open discussion now. You have just showed us how complex this issue is, how difficult it is, how many resources, political will, regulations, laws, culture, behavioral changes, etc. it takes. But if you had to pick one, you only get one aspect that you can fix. Which is the one that you think should be a priority, without taking away the fact that you need multiple different strategies to try and combat this. So thinking in the kind of very broad, big, high level issues, which one would you choose?
So I think I'm happy to come in first, just to reflect from the policy perspective, understanding that a lot of moving of the needle is highly dependent on what the health policies within each country looks like. Yes, indeed, we have put together the Global Action Plan on AMR. We've put in, within that, we've in the national action plans, we've put about guidelines, structures around surveillance, things around IPC. But you have to understand that for any clinician, for anyone to make a change, it's all dependent on the existing policies that have been put in place. Those policies are important for things like financing. It's impossible to say a clinician to do, or a microbiologist to do laboratory testing if there are no policies, enablers in place for things like ensuring that bacteriology capacity is in place. If you insist that doctors must follow a certain sort of stewardship, have we put in place the policies to ensure that the National Essential Medicines List have the right antibiotics in place? You think about things like use of antibiotics in agriculture. That's also dependent on the stringent policies that lead to things like regulations, legislations, what I would call policy enablers. So I think in setting the scene in terms of how behavior not just from the end user, behavior from policymakers, from clinicians, from veterinarians, from even financiers, funders, is all dependent on the existing commitments at the national level or at the global level. So policies, I think, must really be put at the forefront, but not just policies that go beyond papers, beyond websites, but actually to implementation. Back to you.
Thank you. Any other panelists would like to interject?
I will add something to what Alim says, and again, for me, it's very difficult to try to find the specific one thing. But if I have to choose, I will probably get organized national action plans. And the rationale for that is that there is evidence. We know that those countries who do not have organized national action plans have the highest mortality for antimicrobial drug resistance in that country. So we have that evidence in our country. The 7 countries that doesn't have yet a national action plan, they have number 3 still the mortality secondary to antimicrobial resistance. So we know that that's probably the most important factor that will trigger the whole reaction in the whole country. But besides that, I think that more important than that, once you have that, for what I can see in a lot of the countries that actually have national action plans, is having a structure that communicates and reflects what are like the efforts from each country are doing. I can see a lot of discordance, a lot of evidence that is not connected to what the country is doing. One of the examples that I have, for example, is Mexico. Mexico is developing, they have a national action plan, they have a lot of policies, but one of the problems that they have is from their surveillance, we know that the highest carbapenemases that we have is NDM. It's a specific type of carbapenemases that is, it's like the weirdo from the carbapenemases because it's different to treat than the other ones. Now, on the other hand, what is interesting is that Astronam, that is part of the treatment, is not existent in the country. And although it was approved at some point, they let the permission and they are not producing the antibiotic anymore. So although the infrastructure is there, the information is there, there's a lack of communication and putting things together on things that really make sense. So for me, it's not only having the structures, but finding, and what I see in every single country is that lack of communication and that lack of multidisciplinary effort in getting together and trying to put all the information and make a plan based on that information.
Thank you.
I can add a few comments. Obviously, coming from a perspective of living in a country where I have access to many antibiotics, have used many of them. I think for me, the greatest need is development of, investment into the development of novel approaches for treating antibiotic-resistant infections, and not necessarily new traditional antibiotics. And this comes from, my treatment with phage therapy and the success of that. As we know, bacteria are incredibly adaptive and resilient, and so minimizing, I think, rates of resistance would involve, investment into development of approaches like harnessing the immune system and inhibiting bacterial cell interactions, breaking down biofilms, more rapid diagnostic testings and such. I think that there is not a lot of innovation in new approaches for treating infections. And from, my perspective in the United States, and, with not as much of those barriers that exist in the world elsewhere, from this point of view, that is where I see the greatest need.
Thank you. So I hear that there's a need for laws, regulations, plans, investment in research and development. And so there are finite resources and many competing global health priorities in the world. So how would you argue for prioritizing antimicrobial resistance, and what are the trade-offs for that? How can we support and encourage and promote the development of these laws, regulations, plans, and investment on this issue?
If I can make a couple of thoughts on this, is that one of the difficulties is that AMR is not a kind of a standalone. It doesn't happen in isolation, and certainly when you look at in human health, and I think there's examples in the animal health too. Antibiotics are really cross-cutting. It's these words about a cornerstone of medicine, and I mean where we were, let's say 100 years ago or 80 years ago, pre-antibiotic era, it affects everything. And now fast forward, I mean, so as our gains are made with oncology interventions, as our gains are made in, as I say, birth, safe birth, it's a really cross-cutting tool. And so putting antibiotics in the context of universal healthcare, and it really impacts NCDs, it impacts just infection, on its own, I think is a really important twist or pivot that we have to start making. And if we literally lose antibiotics, and even if they're the more novel innovations that come along, that Ella was talking about, we really go backwards by decades in terms of the rest of what medicine can achieve. So thinking about it as a cross-cutting tool, I think is so critical.
Yeah, I think awareness and education is very important. And again, many times by hearing Ella, I get inspired because that's what we want, people in the community that has the awareness. that antimicrobial resistance is not only touching individuals, but it's touching the whole humanity. And the problem is that antimicrobial resistance is not something that we're going to quit and is not going to finish, because bacterials and other live organisms are very smart, and they're going to find a way how to stay and survive in the world, because that's the way how we all animals stay here. So every single bacteria or organisms will find a way to survive in an environment, and that's why they become resistant to whatever treatment we decide to give. So for me, it's a matter of awareness of getting people understanding from childhood the importance of how we live in the environment where we live, and how we need to learn to get through there. And not only from the tip of the iceberg, it's not only to treat those multi-drug resistant organisms, how to live to prevent and live in community with this community of microorganisms that are, although they do bad, but they can do good for us because they live in our system and in our body. So all these campaigns trying to get information and education since childhood of the importance of vaccination, the importance of give antibiotics just when you need it, the importance of animal, I don't know, the reports of like the pets having now multi-drug resistance. So it's the concept of the importance of bacteria in the daily living of humanity, and how that affects our daily living, and how is, for me, part of what warming, the global warming is to the world. For this is my little thing that contributes to that. So that will be for me very important. Like I've seen cardiovascular, people got all the eyes and investment when they found out that what it was and how difficult it was, and that the cardiovascular problems, cancer, diabetes. So we need to do the same, spread information since very early about the importance of the bacterial world in our lives.
Thank you. I want to kind of pivot a little bit and ask about a larger issue, this concept of One Health, and how we are all intertwined with our environment, with animals, with everything that surrounds us. And so, to what extent this concept of One Health is still aspirational in antimicrobial resistance, and where have we fallen short in coordinating all of these human, animal, environmental domains? What structural changes would make that real?
I think that there are already efforts, at least in Latin America. I can see that there are already efforts to try to get through the One Health approach. I could see that the first probably, the Global Health Action Plan came in 2016, and since then, it's just the national action plans trying to go through. And probably the initial priority was human health. Then COVID happens. But what I have seen is over the past 2 or 3 years, there's a little bit more of a culture of trying to get into animal health. I can see the animal health and agricultural are now investing into antimicrobial stewardship. I came back from 1 year ago from one cross meeting from FAO, the Organizations for Veterinary Industry, and PAHO, talking about animal health and how antimicrobial stewardship is part of the chapter of governments in terms of working on implementing antimicrobial stewardship in the veterinary medicine. So you'll see that little by little, once a country gets, and that's why it's so important that the national action plans, once they establish human, inevitable, they will just jump into veterinary medicine and then water and food. So I think that although it lags behind from what is being done in humans, I think that there's a beginning of working towards, specifically with veterinary medicine and antimicrobial stewardship.
So I think really great insight. Same from Africa. I think the concept of One Health has significantly grown over the past years. And a few issues have really brought sort of sectors together, COVID-19 in the African continent being one of the sort of game changers for what a One Health approach could look like. But I think it's quite important to highlight the progress that has been made on the African continent. So a lot of the countries across the 55 countries of the AU have really set up what we call the AMRCCs that have taken on a One Health approach. So in those committees, the national committees, they have focal points from human health, agriculture, and environment. That said, I think there's a lot of opportunities for us to strengthen what the collaboration looks like. A few things are very critical in terms of how we pursue One Health. I think it's been really significant if you think about the progress we've made on the global ministerial meetings on AMR, but also even in the UN General Assembly Political Declaration of 2024, is that the One Health approach helps us accelerate the political commitment and leadership. You'd agree with me that AMR is not just a public health issue, but really takes on the ecosystem, also the whole system sort of approach, agriculture, trade, and all of that. But I think most importantly for LMICs, the One Health approach offers a sustainable financing mechanism. The human health sector does not have as much budget at the national level to address all the critical elements of AMR. But through a coordinated approach of the One Health, you're able to take in resources, not just from the human health sector, but also leveraging the existing resources, going to agriculture, going to environment, and going to other relevant sectors. So I think the One Health approach, yes, there is a lot of work that we need to do, but I think the global sort of conversations, such as the pandemic accord, has really helped us accelerate those collaboration at a national level. Back to you.
Thank you. So in the last 5 minutes or so, we seem to be on an unsustainable path. That's what I get from this. So if you look at the next, say, 20 years, just project yourselves 20 years from today, and you were at that point and you say, what could I have done in 2025 to change what the reality is in 2045? What would you do right now that you think could change this trajectory?
I think that strengthening more prevention. I think that a lot of efforts are done just because of the emergency. You know, when you have antimicrobial resistance, the initial reaction is to, it's just if there's a fire, just cool off the fire and try to treat the antimicrobial resistance, treat the diseases, do infection control. But what are we doing to prevent that? So I always think about as antimicrobial resistance, when you confront the disease per se, is the tip of the iceberg. But if we don't go and get through the base, it's going to be impossible to get to a point. Just to begin with, we know that from here, if we keep doing the same thing, even if it's good, we know that the numbers are not going to be good because the population is getting older. And by the population getting older, we're going to know that we're going to have higher rates of mortality from antimicrobial resistance. So it's like a fight against every single odd that we're going to do worse. So the question is, what can we do in order to not to win a battle because we know we're going to win, but at least to sustain what we're doing? And to me is, if we don't work on the base and what is really causing this, we're not going to go anywhere. That is prevention.
I think for me, it's really AMR is such a wicked problem, but apparently AMR is one of the most faceless crises we face. Unless we're able to put faces on those numbers, to the policymakers, to the people, the pharma industry, academia, it just seems like numbers. I think if there's one thing that I'd really like to change is where we can share the story of AMR, not just as a faceless crisis, not just as a looming pandemic, but something that affects you and I, something that we can relate to, something that, when you tell the stories, even though people cannot see it, like HIV, TB, malaria, Ebola, Mpox, it's something that they can feel very passionate about. I think more than ever, this is the one thing that we all need to change when it comes to telling the story of AMR. And I'm really honored to share a platform with Miss Ella, who really serves from the patient perspective in this conversation. Back to you.
I would very much agree with that that sentiment. I think if we can bring better awareness, and that was already mentioned before, but you know, for our global population and even those that are, specifically could be affected by AMR, like the cancer community, those that are immune compromised, these are unfortunately increasing populations of individuals who you know, who for which awareness is really valuable and needed. And so if we can bring together these, large coalitions of nonprofit groups to, create awareness campaigns and exactly that, bring a face to this crisis and this problem, that's a way by which we are going to really capture and have people from the general population understand and have it be relative or related to them. They can relate to the issue more easily. And I think that's where we currently have this disconnect where AMR to the average person and most people is, even a term that they don't understand. It's abstract. So if we can humanize, if we can bring it right into their own lives and help to create, make it a problem that is important to think about. I think that's how we're really going to start to, bring a lot of the, solutions to, I guess here. Yeah.
Thank you. And yes, no, I couldn't agree more with the sentiment that prevention starts with awareness, and awareness needs to have a face. And it's not just the face of people who have been affected by it, also the face of people that are currently affected with it, and the face of people who will be affected by it in the future, which essentially means all of us at one point or another, in some way, shape, or form, are going to be affected by antimicrobial resistance, whether it is that you have a mild or a severe infection, whether it is the cost of healthcare, whether it is access to the appropriate treatments for you, whether it is any whether it is that you miss somebody's wedding because of that, or any other reason. I think that that awareness that this is not some abstract faceless concept as it was defined here, but it really is something that to a larger or smaller extent will affect every single person in the world, and the ones that will come afterwards, all these newborns that unfortunately suffer from severe infections and cannot grow, how it affects the GDP of countries, et cetera, et cetera, et cetera. So that awareness is really very, very important. I want to thank our panelists, for this fantastic discussion. I want to thank the Health Policy Lab for putting this together and for inviting all of us to be part of this. And with that, I'm going to close the participation. Mr. Batiki, do you have any other comments? Thank you.
Thank you very much, Dr. Baracco. So on behalf of the University of Miami Public Health Policy Lab and the AHF Global Public Health Institute, I extend our sincere gratitude to Dr. Baracco for his thoughtful moderation and to our distinguished panelists, Dr. Alimi, Ms. Balassa, Dr. Lichtenberger, and Ms. Ruffel, for sharing their invaluable insights on antimicrobial resistance. Your perspectives have deepened our collective understanding of this urgent global health challenge, and we will continue to inform our ongoing work toward more resilient health systems worldwide. In closing, we invite everyone to stay tuned for updates from our Emerging Challenges in Global Public Health webinar series, including our upcoming session on the WHO Pandemic Agreement next Wednesday, October 29th. Thank you all so very much, and we look forward to seeing you again.
Thank you.